COVID-19 Military Support Initiative was launched by the Association of Defense Communities, Blue Star Families, and participants of the White Oak Collaborative. It's a comprehensive resource for communities, states, and military families during this pandemic, with virtual events, daily news updates, and ongoing pain points polling. The Association of Defense Communities is a leader in supporting the resilience of communities and states that support America's military. Blue Star Families is a national nonprofit supporting active duty, National Guard, Reserve, veterans, and their families while strengthening local communities. The initiative is presented by Booz Allen Hamilton, with significant support from USAA. Other sponsors include the Bristol-Myers Squibb Foundation, the Association of Military Banks of America, the Military Housing Association, Hunt Companies, J.P. Morgan Chase & Company, and First Command Financial. And now, today's CMSI virtual event.
Thank you all for joining us this afternoon. And for those of you who may not have seen me in a previous town hall, I'm Kathy Roth-Duquet, the co-founder and CEO of Blue Star Families. Welcome. Thank you for attending today's town hall on the evolution of healthcare for veterans during the pandemic. We are really excited to have two senior members of the VA with us today, and good friends and folks who have really been leaders in this field. After they speak, we will be moving on to a dynamic roundtable discussion with the Bush Institute and representatives from Emory and the Marcus Institute. We hope today's discussion will be relevant and engaging to all of you, and we welcome a robust discussion. Before we get started, though, I have a very exciting announcement and a tip of the hat and thank you to Dr. Linda Davis. Blue Star Families has got the news that our MOU with the VA has been approved and is in the process of being signed, and this will allow us to share information and resources and better serve veteran families, particularly in the communities in which we have chapters. So an exciting day for sure for us here. Look for details as they develop. To participate in today's town hall, please go to your chat form on your participant panel for GoToWebinar and just put your questions right in the chat. We will get to them during the panel, and if we are not able to get to them in the panel, our participants on this town hall will provide answers and we'll put them on the website afterwards for all of you. To introduce our first guest today, I would like to welcome Dr. Kevin Vigilante, the Chief Medical Officer and Executive Vice President of Booz Allen Hamilton. For those of you who may not know Dr. Vigilante, he is the Dr. Fauci of the veteran healthcare space, a beloved spokesperson and activist to drive improved healthcare to veterans. We're really pleased to have him with us today. Booz Allen Hamilton has been an incredible partner to Blue Star Families over the years. When we partnered with the Association of Defense Communities, whom they also support, they were among our first and strongest supporters. And this CMSI initiative and these town halls would not be possible without them. So thank you so much, Kevin. May I ask you to join us now to introduce our first panel?
Thank you. Thank you so much, Kathy. And boy, being compared to Tony Fauci, that's quite a compliment. Maybe the only thing we really share in common is that we're both from Brooklyn. So, but at any rate, Booz Allen Hamilton is proud to be the presenting sponsor of this partnership, and I am honored in particular to introduce this session. As a physician who's treated thousands of veterans and now as Chief Medical Officer at Booz Allen Hamilton, I really witnessed firsthand the evolution of veteran healthcare. VA innovations such as the electronic health record and the advancement of telehealth are making an enormous impact in providing more streamlined and comprehensive care and access for our nation's heroes. And this is especially true and important as we face COVID-19 and the national upheaval around social justice issues. These challenges increase the risk of illness, despair, and mental health problems. And our veterans continue to bear a disproportionate risk of death by suicide. This is in addition to the continued need for physical care, particularly for those who are injured in our most recent conflicts, and for our older veterans who may not live near a veteran's facility, a medical facility. It is critical that their experience with VA is convenient, pleasant, inclusive, and seamless. And that is why I'm so pleased to introduce your keynote speaker today, Dr. Linda Davis. Dr. Davis serves as the Chief Veterans Experience Officer for Veterans Affairs, and she's nationally recognized for her leadership in the development and implementation of programs that support quality of life services for military personnel, veterans, their families, caregivers, and survivors. I've had the personal privilege of working with Dr. Davis for many years, and I'm constantly amazed by her energy, her brilliance, and her vision, but most of all by her impact. I'm just going to touch on a few highlights in her long and distinguished career. Dr. Davis previously served as the Deputy Undersecretary of Defense for Military, Community, and Family Policy and the Deputy Assistant Secretary for Military Policy for the Navy. As the designated Joint DoD-VA lead to the Commission on Care for America's Returning Wounded Warriors, she initiated the DoD and VA's use of comprehensive family-inclusive recovery care plans and launched the National Resource Directory. Prior to joining VA, Dr. Davis served as the Executive Vice President at TAPS, where she was the Executive Director of Military and Veteran Caregiver Network and CEO of a service-disabled veteran-owned business specializing in education, training, health, and human services. A former clinician at a VA medical center, Dr. Davis served on the faculty of the Departments of Psychiatry and Public Health Administration at the University of Southern California, where she earned a PhD and a Master's of Public Administration with a specialization in Human Services Administration. She holds a Master's of Arts in Community Clinical Psychology. Dr. Davis serves on the boards of the Veterans Advisory Council on Rehabilitation, the Defense Advisory Committee on Women in Military Service, the Elizabeth Dole Foundation, the Student Veterans of America, the Virginia Wounded Warrior Program, and the National Council for Adoption. She is a former Army Signal officer and the mother of a veteran. With that, it is a distinct privilege and honor for me to introduce Dr. Linda Davis. Dr. Davis?
Thank you very much, Kevin. And if we were close enough, I would have cut you off earlier, my friend. Thank you very much. It's embarrassing to hear about yourself, especially at my age. Thank you all for this opportunity, and thank you very much, Kathy, for bringing this important coalition together. I have a few slides today that will complement some other things that you'll be hearing from my VA colleagues and others who share our joint commitment to our service members, veterans, families, caregivers, and survivors. The bottom line here is, I think as Kathy and Kevin have both said, that the importance is how we make sure that information and services are available to those who have served us. So rather than talk a little about what my office does, I'm the engine with my team that drives customer service in the most innovative ways we can to make sure that those services are delivered to those who need them. And this meant during COVID-19 with the pandemic, with so many changes that we all experienced, that we had to think outside the box. Luckily, I have data, tools, technology, and engagement, and we applied all of those to make sure we were reaching what was needed by our customers because we were listening to them first. Next slide, please. I just want to highlight here, because I know our time is short, some of the key things that we were able to do. One of the things that we did was make sure that we're connecting with our veterans and their loved ones. You all should be receiving, if you're not, our e-newsletter, Vet Resources, which is news to use. We've sent out during this time over 81 million of these vet resources, and anyone on the call with a service or resource can be part of that e-newsletter and get their information out. It's very well received. 11 million people each week, and veterans are clamoring for the information that's in there. We have vet text messages. Just so you know, when facilities began to expand their services to the veterans in the community they serve that were not just pandemic related, we were able to text veterans for the first time and let them know when the facility would be opening up, what services it would have, and how they make their appointments. This enabled them to be informed without having to try to navigate the system and get the information that they need. We're doing numerous live outreach Q&A efforts, and you'll see some of the data down there. These we do together with organizations on this event today, and we couldn't do it without our community-based partners and other federal, state, and local agencies. The way we interact with veterans has changed now, and I'm of the mind that it will continue to and evolve, and it will forever be different. You'll hear more about telehealth later, but we are in a virtual environment, and that's the way we need to go forward, understanding how our veterans want to understand that. So on the rest of this slide, you'll see the way we deliver information. We even have a way now, of course, you've heard this, stay in your car, we reach you when you're ready. The Chatbot feature is a very, very useful one. Most importantly, I feel, is our lines that allow a veteran or loved one to reach us and talk to a live, informed, instructed agent 24/7, 365. So you see under there our reference to our VA 311. That's really our information directory. That's largely how do I find X, Y, and Z, while the White House VA hotline is how I get my particular needs, my question answered. And this is linked into the entire department and lets us let VHA or VBA or cemeteries or the board or a staff office know with one call what service a particular veteran needs. And because we operate it, there is accountability for service recovery. And so we know how many veterans are being responded to and when and how long it takes. I'm really, really honored and excited and pleased that because of so much of the training we have done over the year, we've trained over 100,000 of the VHA employees, for example, on something called Own the Moment, teaching people how to be present. We have our trust scores, our delivery of the services, both in person and virtually, have improved so much. So we are able to have an increase in our trust scores, particularly for the outpatient services, even during this time. And that is that's a tribute to the employees who work with us that have been referred to. Another thing, the next slide, please. During COVID, not only did I mention that we have our 311 line and our White House VA hotline, but of course we have the crisis line. Kevin alluded to the challenges that our veterans face and their family members with mental health and suicide. And we do warm handoffs not only with the veteran crisis line, but with the homeless line, whether a veteran calls the 311 for information or whether they call the helpline in the middle of the night and need help and happen to be at risk. You see, just during the few months of the COVID, we've answered over 63,000 calls. 97% of those cases have been resolved. The ones that aren't resolved, it's just those are more recent in the queue. And we have done that warm handoff 75 times, helping save the lives of veterans. Next slide, please. We know that not everybody feels comfortable calling, or they're looking at our website, et cetera, multiple ways that people get their information. And we want to make sure everyone is ready to respond to that person, and that things are in clear and understandable language that are usable for the purposes of navigation, access. So we started quick start guides. This is something we've done with our VA welcome kit that you've got to get a copy of. And we'll make sure you have the link to that if it's not in here. These tell an individual customer, veteran, family, caregiver, survivor, how to access our benefits in very quick, easy terms. You'll see at the right of the screen, it describes this particular one that we launched really within weeks related to COVID-19, how to get your services in there. We also have ones that relate to survivor benefits because, excuse me, we found that unfortunately we had new cases of survivors or new circumstances of survivors for those that did succumb to either the coronavirus or other conditions that they had during this time. We have some for caregivers, augmenting the information we're able to give caregivers about the services we have. So this is another assistance. If people have an awareness of a constituent customer group that is finding it difficult to navigate a certain area of our services at VA, work with us to create some quick start guides. There are numerous, they're all provided in the link with the welcome kit there. I urge you to, share those widely. Lastly, for our COVID response, next slide, please. We looked at summarizing everything we were doing, and this particular reference here relates to what we did primarily in VHA. The amazing thing is not only the number of services that were provided, the sharp increase in telehealth, which you'll hear about, but that our trust scores in VHA and outpatient services, et cetera, continued to climb. And then we were also during this time able to initiate new services with VHA, including conducting our annual patient experience symposium, where awards were provided for the innovative work that the VHA is doing to change the course of medicine. And coming out in the next week will be the trust scores and the performance scores that are comparable to the private sector and that demonstrate that even during this most difficult time, that we are outpacing, in fact, the private sector in the delivery of patient experience and the best care. So none of this would be possible without dedicated, trained, supported staff, which is why my office is very excited to not only look at customer experience CX, patient experience BX, benefit experience BX, but also EX, employee experience. And this is what we're doing at VA to drive the Secretary's commitment to customer service and improve the experience for all our veterans, families, caregivers, and survivors. We couldn't do it without you. Thank you for encouraging our veterans to give us their feedback, to participate in all these, and we look forward to working very closely with all of you and to being safe and healthy.
Thank you so much, Dr. Davis. And I want to tell you how much we appreciate for you for pioneering this customer service orientation. It's a big, big institution, that VA, and I know it's been very, very extensive work from you and your excellent staff. And we're really excited for all you had to share and all you continue to do. And thank you for your work on our MOU, which was signed, I heard just minutes ago. So that is excellent news.
Our honor, Kathy. and to help everyone on this, to work with everybody on this call. Thank you.
Yes, and all of the resources that you referred to will be sent to everyone on this call as part of the after action. Everyone will receive links to all of those resources, and they will be live on our CMSI website for people to access in the future.
Thank you.
It's now my pleasure to introduce Dr. Leonie Hayworth. Dr. Hayworth serves as the director of Synchronous Telehealth. That's a big one. And she runs a really exciting program called Advanced Telehealth Through Local Access Stations, ATLAS. This is something that we've been following closely, and I think really speaks to the needs of the folks on the ground. This initiative aims to provide access to telehealth in rural areas by utilizing pods for teleconferencing in places like Walmart stores and VFW posts. Dr. Hayworth, we are so thrilled to have you with us here today. Thank you for making the time to join us.
Thank you, Kathy. And I agree that it's a problem when I can't even say my own job title. So it's certainly a challenge there. Thank you again for the opportunity to be here and to talk a little bit more about what we're doing at VA to keep care open for veterans during the COVID pandemic. So we want to make sure that veterans understand what virtual care tools are available for them to use at home or in a location of their choosing, particularly as we know many veterans are opting to stay at home where that is clinically appropriate and when their providers say it is safe to do so. So on the next slide, I want to talk a little bit about our virtual tools available at VA, and these continue to expand and evolve. My first focus in discussing what we're doing a lot of is virtual care. So that is video or telephone appointments supplemented by other ways of interacting with our health system through asynchronous modalities. So we have our My Healthy Vet online portal. Many of you may be familiar with that or have used that yourself. Main features in that portal include the ability to send messages to your frontline providers, so secure emails, in addition to medication management, and even the ability to request your appointment with your provider online. We have a new mobile app called RX Refill for those veterans who are interested in requesting refills and all the way down to tracking the delivery and being alerted of where your medicine is in the process of being mailed to you. This is an app for you. And then our Annie app, which is a text-based app with multiple protocols. So I use this a lot for my veterans who need medication reminders. They can receive a text or even blood pressure reminders so that they know that I'm thinking about their blood pressure even when they're outside of the office visit with me. Our home telehealth program focuses on our higher risk veterans, and that's been around since 2003. So that was really a prototype and entry into telehealth at VA. So on the next slide, let's talk a little bit more about the video aspect of things. So this is our video platform at VA called VA Video Connect, and it allows us as VA providers to provide care into the home of veterans or into a location of a veteran's choice. So if a veteran's at work and they have some time in their lunch hour, but not quite enough time to make the drive-in, or perhaps they want to avoid the drive-in entirely, because of their concern of being exposed to COVID potentially, they can opt for a video visit into a location of their choice. So a couple of neat features in VA Video Connect that make me feel like the patient's with me in my office in person. So I have the screen sharing feature there on the bar below where I can share radiology images, I can walk through an x-ray, I can show a veteran what their labs are. We can look at trends over time and reports, EKGs, all sorts of things. We also have an emergency contact feature there, which is really nice because if my veteran experiences an emergency while they're on video with me, I have the ability to put in their home address and have that ambulance show up at their home as opposed to dialing 911 where that ambulance is going to show up at my office where the emergency in this case is not. On the next slide, let's talk a little bit more about where we're going in the future with this. So we do have the ability to connect our video to additional Bluetooth so-called peripheral devices. So these are Bluetooth connected blood pressure cuffs, thermometers, weight scales, and even a digital thermometer. This newest digital thermometer allows a veteran to turn on the device with one click, put it up to their chest, and transmit their heart sounds along with a rhythm strip that the provider can see on the video to look at the rhythm and the rate of the veteran's heart, as well as, of course, the ability to detect lung sounds. So where are we going with this beyond that? We have all kinds of touchless monitoring in the pipeline that holds great potential. And we want to make sure here at VA Connected Care that we have our finger on the pulse of the latest and the newest technology to integrate to make sure that we are providing the best and the most comprehensive remote care to our veterans. Next slide. And at the medical center facility, we have really responded to veterans' interest and veterans telling us that they prefer video over telephone. And to that extent, we are all hands on deck with making sure we have the ability to support veterans with learning the technology, helping them through, teaching them the digital skills that they need to be able to use VA Video Connect with ease, so that at the time of their visit with their provider, they can really focus on the clinical meat and potatoes of the discussion, as opposed to any troubleshooting or feeling intimidated in the process and not wanting to give it a try. So we have every layer of our frontline teams, from schedulers engaged to nursing staff to our providers, who are doing both individual and group visits with veterans by video across multiple specialties. Next slide. And in particular, let's talk about what resources are available to veterans during the COVID-19 pandemic. So I've talked a lot about video, and many of our appointments are being replaced from in-person to video or telephone. But what about those veterans who don't have their own device? We want to make sure that every veteran who chooses video telehealth into the home or into a location of their choice has the ability to do so. To that end, we are launching next week a digital divide consult that allows providers to indicate which veterans would benefit from video care and to be able to provide a device to them with the connection. So they'll have that mobile cellular connection paid for by VA in order to engage in that video telehealth. So that's our loaned tablet program. We're expanding that also to a loaned phone program, a connected phone program, specifically for our HUD-VASH enrolled veterans. Tablets have also been used in the inpatient environment for infection control during COVID, so that veterans can use that tablet to communicate with their team, even outside or inside their rooms, without that need for foot traffic, again, really to conserve PPE and to optimize infection control in our hospital areas. We also, of course, have our home telehealth remote monitoring program for those veterans who have COVID-like symptoms or who have been diagnosed with COVID, so that we can make sure that we are keeping an eye on them daily and understanding exactly what their vital signs are, making sure that if they are sick enough to need to come in, that we're ready and we have that information to tell them to do that. I talked a little bit about our Bluetooth peripheral devices. Again, a lot of potential there with our ability to provide a comprehensive remote exam to those veterans who need that. Our Annie app has specific coronavirus protocols. So I talked to you a little bit about the hypertension, the blood pressure protocol, and the medication reminder protocol, but we developed specific COVID protocols so that veterans who were in isolation or in quarantine could be monitored on a moment-to-moment basis with text messages on a daily basis to check in with respect to their symptoms and to make sure that these veterans were staying healthy. And if they were getting worse, to be able to identify who those veterans were and ask them to come in the care into our medical center. Also acknowledging Dr. Vigilante's remarks and Dr. Davis's remarks about the mental health burden of the COVID pandemic. We launched the Coping During COVID protocol to ensure that we are keeping tabs on the mood and mental health of veterans out there during this particularly difficult time. Next slide. So on this slide here, we have multiple ways of reaching out to veterans. So just to wrap up here to say that we have been working very hard to communicate the word of how we can make sure veterans know that the VA is open for care, that there are multiple options to access VA care without actually coming into a facility. And we've communicated this through email, through text message, through multiple mailed flyers and flyers available at the medical center to ensure that we're really getting that word out there. Next slide. And wrapping up right there, and happy to take any questions or comments.
Dr. Hayworth, thank you so much for joining today. I know that you were leading the VA's innovative telehealth efforts long before the pandemic, and your work has come into even sharper focus as a result of the challenges presented through this pandemic. And I also know that your work has made it possible for so many veterans to continue receiving the important services that they rely heavily on. So thank you for joining us today and sharing these evolutions, and for your continued work in the near future, making sure that those are embedded.
It's been a fantastic team effort. Thanks for this opportunity to share our work.
Thank you. So hello, everyone. For those of you who have not seen me on a previous town hall, my name is Spencer Kimpton. I'm the Senior Advisor at Blue Star Families, and I'm now delighted to invite a terrific panel of friends and colleagues to talk from the perspective of another very important stool, or leg on the stool of veterans healthcare, and that's the ecosystem of VSOs and other providers in the country who are as committed as the VA to delivering high quality healthcare to veterans. And we have representatives from several of those organizations today. So I'd like for all three of them to join me at this point. We have Casey Kelly, the Director of Wellbeing and Health and Deputy Director of the Military Service Initiative at the President George W. Bush Institute. We have Sheila Rausch, the Mark and Barbara Klein Distinguished Professor in Psychiatry and the Deputy Director of Emory Healthcare Veterans Program at Emory University School of Medicine. And Jim Kelly, the Executive Director of the Marcus Institute for Brain Health and Professor of Neurology at the University of Colorado School of Medicine. So a distinguished panel, but again, a panel of terrific friends and wonderful advocates within the veterans healthcare community. So with this, I'd like to start off with Casey. Casey, you know, you work with a wonderful set of partners, and you yourself have done a terrific amount of work on healthcare policy and healthcare solutions. I'm just curious, can you share your thoughts about the innovative solutions overall that you've seen for veterans healthcare that have either been accelerated or enhanced or even emerged during this pandemic?
Thanks, Spencer. Good afternoon, everyone. So as you heard from the previous speakers, VA has really led the healthcare community on telehealth innovation and expansion. In the private sector, there are numerous policy and regulatory barriers to telehealth expansion and integrating sort of the digital space into healthcare that really don't exist for federal agencies such as VA. And what COVID did, one of the silver linings is many of those federal and state-based barriers to increasing access to telehealth have come down as part of the pandemic response. Specifically, federal regulations on payment for telehealth services have been relaxed, as well as state-based licensure requirements that limit the expansion. For example, prior to COVID, clinicians were not reimbursed at the same rate for telehealth services as they were for in-person services. Further, licenses to practice healthcare outside VA are really really restricted to a particular state. So if you're living in Boston and you have a patient that lives in Maine, you can't actually see that patient in their home because of the state-based regulations. So COVID has led to a relaxation of both of these barriers, which has led to organizations such as those in the Bush Institute's Veteran Wellness Alliance to develop innovative ways to deliver high quality care for the invisible wounds and increase access to that care to our veteran population. We have a couple of these organizations on the phone with us today that I'm really glad we're able to highlight, because I've just been so impressed with how quickly they've been able to pivot to this new virtual world of healthcare delivery. So those are just some two things that I've seen happen very, very quickly. We've probably seen, from a policy perspective, acceleration for telehealthcare delivery, like that's been forecasted to be something that would take years, if not decades, we've seen happen over the past 4 months.
Yeah, thanks, Casey. And I'm encouraged by many of these evolutions and innovations, but want to ask you a question on the flip side, I guess. And I'll ask it in two ways. The one will be kind of colloquially, like, what's keeping you up at night? What are the things out there that are kind of lurking or actually have been similarly enhanced, like challenges or obstacles that have been enhanced through this that still need a lot of work?
Well, while the pandemic has accelerated the adoption of telehealth from a clinical perspective, as well as from a consumer veteran perspective, many healthcare organizations remain hesitant to fully adopt and expand their telehealth programs as long as these policies are only temporarily changed. So currently, we're not seeing any calls to Congress or federal agencies to make the relaxation of these barriers more permanent, which would increase telehealth access more permanently overall. And actually, the temporary policies are expiring very, very soon. So that's keeping me up at night. And then the second thing that's keeping me up is something I've only recently become fully aware of. It's that many may not be aware that we in the United States have a pretty serious digital divide across our country, with approximately 18 million households who do not have access to broadband internet. Our Bush Institute Veteran Wellness Alliance partners have shared with us stories of veterans who have needed to drive to a local hotel that was only a mile away, but still they had to leave their home in order to access the hotel's internet in order to get their mental health care. Surprisingly, the majority of these broadband limitations and the digitally disconnected households are not in rural neighborhoods. They're in urban areas. And the states where this is the biggest problem are the states with the lowest broadband adoption rates, are also the states that have the lowest median incomes, highest percentages of communities of color, and many of our populations that may be more vulnerable to mental health challenges. And it's unfortunate because at the Bush Institute, we know that mental health and brain health challenges are treatable. And while we have seen incredible innovation over the past few months, we firmly believe that we have to take action today to make sure that more have access to these solutions in the future in order to offset that mental health crisis that we are seeing on the horizon.
Thanks, Casey. I'd like to return in a few minutes to perhaps some of those actions and solutions that you were just alluding to. I want to make sure we have the opportunity to turn to some of your partners, and want to shift over to Sheila at Emory. Sheila, can you share a bit about what the Emory Healthcare Veterans Program does, and in particular, what modifications have you made to ensure that your veterans are getting treatment through COVID-19 pandemic? And Sheila, there we go.
There we go. Emory Healthcare Veterans Program has actually really seen this as an opportunity to implement some of those loosened guidelines with COVID, but we've also been a bit challenged being within a healthcare, the Emory healthcare system. So Just to speak broadly, the Emory Healthcare Veterans Program provides what's already an innovative model of care for PTSD and other invisible wounds of war by bringing people from all over the country to Atlanta for 2 weeks to hammer out their treatment. We're getting amazing impact on symptoms, reduction in PTSD, depression, pain, all kinds of outcomes. And in addition to that, we're getting retention that's way higher than what we get in standard outpatient care for PTSD. I've been working in PTSD treatment for over 20 years. It's my passion. It's what I want to do with my life. And I want to continually improve and get more people the care that they need. So that's what we do at the Emory Healthcare Veterans Program. So when COVID came up, we were already trying to figure out models for virtual care before COVID. So we quickly switched and took advantage of the opportunity to build an entirely virtual model of our 2-week IOP and implement it. And we're able to do that within Georgia, and we're able to stretch that out for a little bit into North Carolina and to some other states with the temporary COVID things, but that's all retracting now because of things expiring and protocols changing. So what we are actually working on now is setting up permanent teams for virtual IOP in different states and looking at the permanent licensure laws and practices so that we can actually make some models that are going to be there regardless of whether we have COVID or not. So that's the one big thing we've done is reaching out to do the virtual IOP. Now we're in kind of a limbo mode where we've started seeing some people face-to-face again on a limited basis in compliance with CDC guidelines. So it's only a small number of patients, and what we've developed is actually a hybrid model of care where we're limiting contact, face-to-face contact, but still having veterans come in to get their treatment in groups in a virtual format. That's compliant with CDC requirements. So basically we're trying to start back the face-to-face at the same time as we're expanding the virtual care. The other thing that's nice with virtual care is that we can offer a wider variety of services with these permanent teams, that we may actually be able to offer standard outpatient care for those patients who want that, as well as this 2-week intensive model of care. And I think I said all of the key things that I wanted to say about our modifications. And I'll also have a couple of slides in the resources that people get after.
Terrific, Sheila. Thank you. I do want to, I mean, if we set aside some of the barriers from a licensure point of view and how you would hope to expand this virtual model out, beyond Georgia and, perhaps North Carolina, what you were able to deliver in Georgia from a virtual sense, how did that format work?
It was amazing. So there are pluses and minuses, I would say, but a lot more pluses than minuses. So the patients who were willing to give it a try, because some people are a little hesitant with virtual anyway, but for the patients who are willing to give it a try, they got to do all the same treatments, all the same pieces that we offer face-to-face warriors virtually, without leaving their homes, without having to travel, being able to see their families in the evenings. And I'm a very data-driven person, so we looked at outcomes to make sure that they weren't having substandard changes in PTSD, substandard changes in depression. And we actually saw that they were having the same level of change as the people who would come for the full 2 weeks. So they would get standard PTSD treatment, they would get anger management, yoga, we have virtually yoga, additionally some med management groups and med education groups, substance use disorder assistance as well, and really the whole package of what we offer in the face-to-face IOP.
And Sheila, and before I move over to Jim, I'm just curious if do you expect in the world on the backside of all of this that some of these virtual components to actually reside as permanent parts of your delivery?
That's our intention, and we're actually that's why we're pursuing permanent teams, especially for the states where we get the highest number of referrals. So like Texas, for instance, we get a lot of people who want to come to our program from Texas. So being able to actually offer that virtual option just as a standing option is going to be wonderful.
Thanks so much, Sheila. I want to move over to Jim at this point at the Marcus Brain Health Institute for Brain Health and ask a very similar question. Can you talk a little bit about how the Marcus Institute delivers services generally, but also how those have been modified through the pandemic?
We've had the opportunity since we opened in 2017 to be visited by Secretary Wilkie and by Dr. Linda Davis, and during that pre-COVID era, this was described and shown as a residential 3-week intensive outpatient program. Patients stay on our campus and receive hands-on physical therapy, neurological evaluation and treatment and such for persistent problems related to traumatic brain injury. And so in the COVID era, along with some of the very same psychological approaches that Sheila was just talking about, since some of these patients have comorbid, if you will, psychological and neurological problems, we have found that the telehealth opportunities are such that we can get people in their own homes without having to travel long distances within the state of Colorado to do much of the same kinds of things that we were doing before. The limitation, though, Spencer, that we've been finding is the actual detail with which you can determine physical problems related to persistent concussion effects is a striking challenge within the telehealth world. So I've been hearing this from my colleagues all throughout the medical community nationwide, that the preference would still be to have face-to-face, hands-on, detailed diagnostic workups in the medical and physical sense, and much of the rest of it can still be provided remotely thereafter. But so much is actually missed under the circumstances. I'm concerned a fair bit that I and my staff will miss something, and that's never reassuring when you're trying to take care of somebody with these complex problems. So we're moving as quickly as we safely can toward what we're calling a hybrid model, where people will come in for those evaluations on campus very similarly to what had been provided before, and either go back home for the remainder of the weeks of care or stay elsewhere in a location that we actually possess on the campus, or even off campus if they choose, in a hotel, if they feel safer that way, to conduct the care in a remote fashion, much like we're having these conversations right now. Some of it can be done very well and very powerfully, as you're hearing. That's been our experience as well. But we look forward to the opportunity when we can actually have people back in our presence.
Absolutely. With that in mind, and not knowing how long it will be until we have folks back in presence in full capacity, what concerns have you heard from your patients about being isolated during this pandemic? I mean, you mentioned a second ago, complex issues that many are dealing with. What are their concerns, and is there in particular a special role for organizations like yours or the BSO community more broadly considering those challenges?
I'll be interested to hear what Sheila says about this. Our feedback from patients has been a bit mixed. Some people with persistent TBI symptoms, dizziness, difficulty tolerating bright lights, loud noises, commotion, and so forth, they're perfectly happy to stay in their basements and then self-reduce those triggers and the barrage of what life has that causes trouble. The problem we see with that is, from a TBI care perspective, is then they typically don't get better dealing with those very triggers and symptoms. And so we don't want to encourage that. So even now, we will encourage people to be out and about. We actually take them out as best we can and I'd be interested in hearing how others do that as well, so that community access, outdoor activities, and so forth that are still monitored from an audiovisual perspective, as can be done safely, are still conducted, trying to simulate what it is we would do if we were in their presence.
Yeah, Sheila, Jim tossed you the hot potato also.
Yeah, so I would say we are really trying, because of the constraints of COVID, because some patients won't come to virtual, and we can only see a handful of people with the hybrid face-to-face model that we have. We have a lot of people on our wait list right now, which isn't what we like, but it means that we're following them to do activity planning, to try and keep them engaged with their community, to reduce the incidence of depression, isolation, because they are at a much higher risk of getting so isolated that they start thinking about hurting themselves. So that's what keeps me up at night, is how can we keep people connected? It doesn't necessarily have to be with us, but with some people in their community at the very least, so that they're not feeling like they're alone, because that's when people are at risk of that. So.
Absolutely. So Casey, I mentioned I wanted to return to you, taking some of these concerns and moving them to action, which I know that you and your colleagues and team members at the Bush Institute are always focused on, and always driving through your partners and on your own shoulders as well. Here today, we probably have individual veterans who are joining. We have leaders from BSOs who are likely listening. We have probably representatives from agencies and departments and corporate partners. When you consider that ecosystem, what are the things that we all can be considering in terms of actions, whether it's related to policy change or using our voice in a different way? What are the things that we could all do?
Something that everyone can do, actually, Sheila alluded to, and that's stay connected. Social connection, social connectivity is one of the best things that all of us can do to proactively maintain our health. And that's something that we're encouraging our Veteran Peer Network partners to think about. Just because we physically can't be together doesn't mean that we can't be together and we can't check in on each other. These are unprecedented times, and there isn't anyone in my network that hasn't had a day or two or 10 or 20 in which they're struggling. And we're asking people to go above and beyond their normal routine, and it's adding a lot of stress and a lot of anxiety and a lot of sleepless nights. And the reverberating impact of all of that is really worrisome. So we can all be a good neighbor and check on our friends. As far as policymakers go, I really would like to see some of the short-term regulations that have been relaxed as a result of the COVID response be put in place more permanently. I think that will help our healthcare system overall, increase access to care. And then, the thing that I think what you've heard today from our experts is that we are now beyond a one-size-fits-all model of care for mental health. And we need to all be thinking about how we more precisely match the right type of care at the right time to meet our consumer needs. President Bush likes to say, right care, right time, right place. And I think that is the goal that we all should be striving for when it comes to mental health care delivery in the future.
I like it. I do. Just not closing quite yet, but almost closing. I'm just curious, is there anything on this licensure piece in particular, which seems to be a particular challenge, that is a key next step? Or is this a state-by-state effort, or is this a national effort? Is there anything particularly?
Well, so I think it depends. For the psychologist on the phone, we're actually already seeing some momentum happening, and it began prior to COVID, but COVID has really accelerated it. And the association that basically governs state licensures have come together to create what's called a psych pact. And we have now 15 states who've come together and agreed to acknowledge interstate licensure. And they had to actually work with each governor in those states to get the state license changed. My hope is that when we start shining a brighter light on that work, other mental health professions are going to recognize the opportunity, and we will see some movement happening with our social work community and our licensed counselor community. But where the federal agencies can come in and where we're calling for action with the next COVID relief bill is related to an update to the broadband strategy across the United States. The last time it was updated was back in right after the 2008 financial decline, and it hasn't been updated since then. But Congress and our federal leaders saw the opportunity now back then as part of that relief package to seize the day, if you will, to both financially and economically incentivize broadband expansion, but also it had rippling effects for our healthcare and education communities. So we're asking for that to happen with this next package of relief, that we not just think about the physical health and the financial health, that we really think about our mental health and education needs.
Thanks for sharing that, Casey, and thank you for bringing us home on this call. We quickly made it to the end of our hour, and I want to thank Casey and Jim and Sheila. You know, as ever, it's terrific to see you and hear from you. And on behalf of everyone who joined today, as well as the much broader veterans ecosystem and veterans across the country, thank you for the work that you do every day, particularly through this pandemic, but before and long after as well. So really appreciate you joining me today.
Thank you, Spencer. Thanks, James. Thanks, Sheila.
Thanks for having us.
For everyone else on the call, you've also, in a way, brought us home, us being the COVID Military Support Initiative. Today was our last town hall for the time being. Some of you have been joining with us over the past 4 months through many of these town halls. And today was our last, until the next, I should say. So the reason I say that is that we will be coming back in the next month or two to share all of the lessons learned through this pandemic, as well as some recommendations for the future. We're looking at for that in late September. So stay tuned for that culminating virtual event. Be sure to check out the website, which will not only share those details, but will continue to share resources with you and your family or your business or your nonprofit. We'll continue to update it with pertinent and timely information for the next few months. I also want to remind you to please check your email following this town hall. You will receive information that we promised during the call, and you'll also receive our post-webinar survey. Please take a moment to take that. We really take all of your feedback to heart. And we incorporated in much of the information and resources that we share through the TMSI. But finally, thank you for joining us today. We wish you all the best and hope to hear from you and see you again soon.